Welcome to the patient advocacy issues in the area of pandemic and digital health. I am Roberta. I am a ThyCa volunteer, and I'm happy to be hosting this afternoon Dr. Erik Blomain. And just before he gets started, I wanted to let everybody know that this session is being recorded.
Thank you. Yeah, thank you for the introduction, and nice to meet you all. My name is Dr. Erik Blomain. I'm currently in my last year of residency in radiation oncology at Stanford, and I'm also a patient advocate for thyroid cancer. So I'd like to spend some time today talking on some issues of patient advocacy in kind of this modern era of technology that we find ourselves in, and what some of the implications are going forward as I see them. Talk is not really about me, but just by way of introduction, I began volunteering in ThyCa in 2017 in Philadelphia area. I have been training in medicine for some time, but this kind of support group work and work with patients was kind of a different level of patient interaction and kind of more rewarding than I had experienced. So I really discovered a passion for kind of that aspect of the work as well. And so I ultimately applied for and was accepted as the patient advocate for the NCCN Guidelines Committee on Thyroid Cancer. And that's a platform where I kind of try to promote patients' best interests in a set of national guidelines that are widely used by physicians to guide care. All that is to say, I didn't have any formal training in patient advocacy. So I found out early on that I had to kind of define it. What do? You look it up, you Google it. The NCI has a really good glossary of cancer terms. This one is kind of clunky, but I think it's technically correct. I looked at Wikipedia, the usual spots. If I'm going to be a patient advocate, I should kind of know what that means, right? I think most people have a concept of what it means, but when you actually have to sit down and define it, it gets a little bit tricky. So I ultimately came up with my own working definition that I'm going to use throughout today's talk. And the patient advocate is someone who endeavors to ensure that the needs of patients are being met and that their unique voice and perspective are heard in matters that affect them. And so you can see it's a pretty broad definition. I think it's a pretty broad term, so I think that fits. And another way of saying that is communication. So the first kind of segment of the talk here is going to focus on how communication is changing in our world today and how that affects healthcare. And that could be communication on a micro level, or it could be communication on a macro level. And so that could be one patient talking to their own physician, or it could be looking at a community or governmental level policy and everything in between. And so communication in healthcare obviously starts fundamentally at the doctor and the patient, but there are barriers to that. And a lot of these barriers are going to come up as we talk about how these barriers apply to the digital health world as well. So the patient, has their own set of fears and motivations, and these are things that everyone that has either cared for someone with cancer or who has gone through it themselves has in some way, shape, or form experienced these. And then the physician, on the other hand, which I've been fortunate enough to experience that side of things as well. We're very afraid of failing the patient, and there's barriers to struggling to kind of teach and explain, and time pressures. But in the end, everyone kind of wants these ideal communication relationships. So, again, I'm kind of laying these out as paradigms because I think as we talk about the digital advances in healthcare, it'll become clear of how some of these things are being affected. But, I kind of just have some general advice from kind of my experience on both sides of the doctor-patient relationship. At the end of the day, you are your own advocate, and you will have advocates societally or at the hospital or whatever, but at the end of the day, you have to be to some extent responsible to kind of having the communication that you want. But obviously there are challenges, but then on the doctor side, I say I don't know all the time. I think it's very important to kind of listen for the question behind the question. So they might not be asking what's the lab value mean, they might be asking, is my cancer coming back? Things like that. And so, I challenge my colleagues to always kind of look for the question behind the question and express empathy. But you can imagine that as society has kind of moved, we don't meet face to face, we Zoom, we text, we don't even like to pick up our cell phones anymore. That these fundamental communications that drive successful doctor-patient relationships and successful care have the potential to be undermined by this. You see this as kind of an ideal. you know, all these different kind of healing touch doctor-patient relationships. This is kind of this is a cartoon from the New York Times. It accompanies an article which I'll get to in a few minutes. But yeah, it's all about kind of even the slightest touch. Some physicians believe, and some patients believe, is kind of has its own kind of human interaction and healing associated with that. But then you contrast that to what's the reality that many of us see in healthcare, which is the electronic medical record, screens. Yes, the care is patient-centered, but this is not, I think, what we would say literally being in the center is what is all about. So, where do we go from here? How does this actually playing out? And is this lost art of medical touch really affecting patients? It's a little bit tacky, but if you'll forgive me, I think this TED Talk, there's a short clip I want to play from this talk on this exact issue that I think, they always say, if someone said it better, kind of use that. So I think I'm going to go with that for this part of the talk, and then we'll kind of circle back to what it means. So without further ado, I'm going to pivot to that tab. Here we go.
Ladies and gentlemen, that is not an unusual story. Unfortunately, it happens all the time. I joke, but I only half joke, that if you come to one of our hospitals missing a limb, no one will believe you till they get a CAT scan, MRI, or orthopedic consult. I am not a Luddite. I teach at Stanford. I'm a physician practicing with cutting-edge technology. But I'd like to make the case to you in the next 17 minutes that when we shortcut the physical exam, when we lean towards ordering tests instead of talking to and examining the patient, we not only overlook simple diagnoses that can be diagnosed at a treatable early stage, but we're losing much more than that. We're losing a ritual. We're losing a ritual that I believe is transformative, transcendent, and is at the heart of the patient-physician relationship. This may actually be heresy to say this at TED, but I'd like to introduce you to the most important innovation, I think, in medicine to come in the next 10 years, and that is the power of the human hand to touch, to comfort, to diagnose, and to bring about treatment.
And just slightly ahead, he goes on to talk about a very specific real-world example of this, which I'll share. And then
I've gotten into some trouble in Silicon Valley for saying that the patient in the bed has almost become an icon for the real patient who's in the computer. I've actually coined a term for that entity in the computer. I call it the eye patient. The eye patient is getting wonderful care all across America. The real patient often wonders, where is everyone? When are they going to come by and explain things to me? Who's in charge? There's a real disjunction between the patient's perception and our own perception as physicians of the best medical care. I want to show you a picture of what rounds looked like when I was in training. The focus was around the patient. We went from bed to bed. The attending physician was in charge. Too often these days, rounds looks very much like this, where the discussion is taking place in a room far away from the patient. The discussion is all about images on the computer, data, and the one critical piece missing is that of the patient. Now, I've been influenced in this thinking by two anecdotes that I want to share with you. One had to do with a friend of mine who had a breast cancer, had a small breast cancer detected, had her lumpectomy in the town in which I lived. This was when I was in Texas. And she then spent a lot of time researching to find the best cancer center in the world to get her subsequent care. And she found the place and decided to go there, went there, and which is why I was surprised a few months later to see her back in our own town, getting her subsequent care with her private oncologist. And I pressed her, I asked her, why did you come back and get your care here? And she was reluctant to tell me. She said, the cancer center was wonderful. It had a, beautiful facility, giant atrium, valet parking, a piano that played itself, a concierge that took you around from here to there. But, she said, they did not touch my breast. Now, you and I could argue that they probably did not need to touch her breast. They had her scanned inside out. They understood her breast cancer at the molecular level. They had no need to touch her breast, but to her, it mattered deeply. It was enough for her to make the decision to get her subsequent care with her private oncologist, who every time she went, examined both breasts, including the axillary tail, examined her axilla carefully, examined her cervical region, her inguinal region, did a thorough exam, and to her, that spoke of a kind of attentiveness that she needed. I was very influenced by that anecdote. I was also influenced by another.
Okay. This whole TED Talk is great. I would encourage anyone that's interested to look it up. Those are the moments that I found most meaningful. So I wanted to share them with you because, again, I think it frames the rest of what I wanted to talk to you guys about. But so you can see a pretty compelling argument in a personal story shared about the art of medical touch. And you can use, in my opinion, medical touch as kind of a surrogate for, face-to-face interpersonal communication and the doctor-patient relationship. This is that New York Times article I referenced as well. It references lots of people that kind of have experience in medicine as it was, so to speak. I kind of relate to this in some ways because my grandfather was a small town general practitioner in Pennsylvania as well. So, I have kind of a longitudinal experience similar to what is espoused here. And to the point where you can kind of, even in my lifetime, see the contrast based on my experience with my family and the challenges that our modern era can portend. But I will challenge by saying, is it all bad? I think that I framed and kind of gave that TED Talk and the New York Times article to kind of show one perspective that I think is shared by many doctors. You'll see physicians almost like wax emotionally or philosophically about kind of the good old days and the physical exam. You saw it at the TED Talk, the old days of rounds. I think there, clearly was excellent medicine being practiced in those days. But, the flip side of all the modern diagnostics we have is that we have all the modern diagnostics. He said you could argue that we didn't need to do that physical exam, and maybe we didn't. I think that there's this, natural human nature to kind of long for the good old days. So I think some of that is at play when doctors talk about how modern medicine, the electronic medical record and things like that, rounds remotely, are kind of undermining things. I think it's important to kind of have a critical eye on that, both as patients, because is that really what's best for us? But then also even among my colleagues, like, are we really kind of looking at an ideal that was real? I'm going to get more to this later, but medicine as an institution historically was rather paternalistic and saying, we know what's better than for you than you do. I think there's some kind of component of that as well with this medical touch thing. I think I think the world has moved more towards a consumerist model of almost everything. And so I think, that's coming to medicine. And I think we ignore that at our own peril. I think, what patients are willing to accept in terms of customer service, even though that seems kind of funny to talk about medicine that way. I think to some extent, they might not care about the academic implications about whether or not a physical exam is necessary, kind of in the big picture. So I think we can wax philosophically all we want, but I think at the end of the day, disruption might be coming. And so I think it's better to stay ahead of that and always focus on kind of the evolving needs of the patient in a modern world rather than kind of longing for the past. But in all of these things, you can kind of spiral. You'll have strong opinions on both sides. I'm kind of I submit to you that I think by the end of this, you'll see that I cut a middle road. But I think ultimately, when you're in these kind of areas with strong opinions, I think it's always good to ground your opinion in data wherever you can. And so I want to spend some time talking about the data on these digital issues and what that looks like. So, I said that doctors will talk about the good old days and say, we want physical encounters, we want physical exams, we want face-to-face patient communications. So, now that everyone's doing video visits, are those visits really worse for doctors from our perspective? I think I was surprised by these data. I mean, I'm not surprised that the phone visits did poorly. Just to orient you, basically this black line indicates kind of like the cut point at where people said were like unfavorable versus favorable in terms of their opinions of these different types of visits. So I'm not really surprised to see phone visits. I almost don't even call those visits. It's more like calling someone with a lab result or something. So yeah, I don't really expect that to be a doctor-patient encounter. But when you look at video visits, we're interacting over video right now. I think Zoom and web clients and things like that have really kind of like revolutionized our way of communicating to a large extent. I was actually surprised at that about 10% or so unfavorable, but mostly, almost 90% favorable. So, despite these, kind of almost like, melancholy cries for yesteryear, I think we're actually seeing that, for the most part, these are going pretty well. And when you kind of break it down to like, what are they good for and what are they not good for? I think common sense kind of wins out here. I think things that this was not surprising to me, that the things it's best for, I even mentioned in the last slide, kind of calling someone with their lab results, right? Like to review, like, oh, you had your 3-month scan, everything looks good, that kind of video visit. I think a video visit's like totally appropriate and actually really great for that. But you can see the least kind of favorable reviews from the doctors came from their perceived ability to establish personal connection with a patient or family. Now, interestingly, which we'll get to, this is not the patients saying this. This is the doctor feeling that they were not able to establish a connection with the patient and the family. I think it's interesting when I kind of spoiling it a little bit, I will soon transition to the patient perspective. I think it's interesting to see where these things line up and where they don't. But that being said, I think that, the video visits actually really do provide a good option. Can you assess that over a video visit? I think we're still learning the answer, but the physicians in this study felt as though they could not. I think the data will be interesting to see whether or not we actually can. Like, are we missing these diagnoses in video visits? I think the data is immature on those, so we don't know. I think that's because these are all, kind of reported outcomes from physicians, from patients, but what is the actual kind of raw data going to show of their actual outcomes? And, those data take a year to mature. So I think we're waiting on those. But I think those will be very interesting in the future as we kind of get further out, or I don't want to say further out of the pandemic, I'll say further into the pandemic, unfortunately. So that was cancer patients in general. I think it was actually specifically radiation oncology visits that I just showed, which is my specialty. So kind of frame it in that way. But this was specific to thyroid cancer. This was a result of a Memorial Sloan Kettering kind of physician survey. But again, it's from the physician's perspective, the experts, and what they thought was an acceptable and unacceptable way to have telemedicine visits versus in-person visits. Things that would require an exam is the kind of the take-home version versus things that kind of can be done remotely. It kind of riffs on the same thing we were just talking about, but this is specific to thyroid cancer. Interestingly, though, which you might not pick up on, but anyone who's been doing healthcare during the pandemic has seen this. There are still patients that just cannot do it. They can't do video visits, and so I think it's always as society trailblazes forward, it's always kind of good to keep in the back of your mind that either, there's a myriad of reasons, but, there's socioeconomic reasons, there's kind of like age-related reasons, kind of cultural reasons. We just have to be kind of attentive to, making sure everyone has access to this if they need it, but that, if they don't have access, that's not a barrier to their care. And that's another area where advocates need to kind of be vigilant, anywhere where there's a chance for a patient to kind of fall through the cracks. I mentioned I was going to get to the patient perspective. So this is a colleague of mine. She was actually recently our visiting professor, Dr. Chino at Memorial Sloan Kettering. She looks very, very much into kind of patient survivorship, financial toxicity, all kinds of humanistic concerns in cancer. She's really great. She helped me put some of this work together. And so, again, the doctors thought that certain aspects of the video visit were lagging behind. But if you look at these data, there's really no significant differences between the ratings patients gave to the office visits versus the telemedicine visits. And while it doesn't necessarily talk about like directly making relationships with family, I think it's not difficult to infer that, when someone's friendly, they show concern, they give explanations, that the relationship is being built. So I do think this is interesting, that patients don't perceive the thing that the doctors seem to perceive. And so I think it's easy to forget that, I learned this in college. I was doing some recruiting work, and I had a spiel that I was giving all the time. And I started realizing that the people I was giving the spiel to hadn't heard what I was saying before, but because I had seen it so many times before and kind of said it, I was kind of almost like assuming that they knew what I was talking about more than perhaps they actually did. I'm wondering if there's some phenomenon where doctors have this like idealized spiel of their physical exam, their visit in the office, that they think this is how it should go. Whereas the patient's coming in as a clean slate every time for the most part. I mean, most people have some frame of reference for the healthcare system, but most patients don't have a frame of reference for cancer care. So I'm wondering if like this kind of experience that someone's kind of gotten through their whole career to this point doing things a certain way, if that's not biasing the physicians against these remote visits, because clearly, at least in this study, the patients weren't really seeing a big difference. And if you look, it's not all, great. There are some areas where, some patients felt office visits were better, but I mean, if you look at, there's much more blue and red, which is telemedicine's better or no difference than there is green. And so I think that this is worth noting. I think again, there's not really a clear preference from the patients to do one or the other. And that includes things like, comfort, amount of time, confidence, understanding, personal connection. Again, not many people thought it was better, but, most people didn't think it was worse. So, I think that maybe some of these fears about the telemedicine boom striking down our doctor-patient relationships may be largely unfounded. And I will say, just personally, I sometimes feel like I get to know my patients better. It's like, oh, you have like a giant painting on the wall behind you. What's that about? And like instantly there's a kind of area of connection that we never had before, where they see picture of my dog on the wall behind me. It's like, oh, like, hi, like you have a dog, like I have a dog too, like, so actually it's weirdly kind of led to some connections that might not have been there previously. So all that is to say, I think these tensions are interesting, and I think it kind of bears further research. I think it bears careful consideration as we move forward. But one thing I do want to mention is that we're talking about all these kind of abstract concepts about doctor-patient relationships and kind of ability to form human connections, but there are some objective considerations as well. And financial toxicity, which is kind of defined as patients' financial hardship as a result of their cancer care or their healthcare in general, that's not to be taken lightly. I think, there's an emerging understanding that this is really, really a bad thing to do to somebody, to put a patient in financial toxicity. So I'm going to spend a minute now to talk about that, because you can imagine that, at Stanford, we're a place where patients come from all over California, all over the world, really. But, in California, especially where we see it most, where there's just not access to some of the resources we have in their communities. So they'll drive 3 hours for a visit for me to tell them their PSA is fine. Like, is that really doing someone a service? And so, we're not the only people thinking or talking about this. There's a really great study in JCO, which is a very high impact journal in the cancer world. And this was the Ann Arbor VA. So this is a single VA healthcare center in Michigan. And they looked at, over a 3-month period, this was kind of peak pandemic, what was the actual cost savings, environmental savings, time savings by video visits. And I mean, if you look at it, they're pretty substantial. Again, this is one hospital in Michigan. Stanford right now, radiation oncology, one of our key research focuses has become green medicine. The US healthcare system, I believe, is I want to say 15%, although don't quote me on that. I believe that's the number of our emissions and our greenhouse contribution is from our healthcare system. I believe that our healthcare system produces more than many countries do, like entire countries do. And so again, this is something we're very focused on in our department, but you can see that these are very real savings. We save a lot of time for patients commuting. Honestly, with the advent of being able to do certain remote clinics from home, we save doctors commuting time as well. I mean, and that's like lost time, right? I mean, like, there's all these indirect costs of things, but an hour of my time of day commuting, there are days now where I could do clinic at home. So that's an hour of my time, which is also in the calculus. So, I think this is, I think, very much a sign of our times, because there's kind of like, what is the cost of humanistic concerns? Like, there are pragmatic concerns and there are humanistic concerns. So, we can talk about doctor-patient relationships and what value do those abstractions have versus these real tangible savings. And I don't have the answers. I'm just posing questions. But I think all this work is really interesting, and I think it needs to be part of a larger conversation that we have as a society. I think having video visits here to stay as part of our armamentarium is likely the wisest course of action, and kind of use them judiciously in the ways that we're talking about. This is that same paper. It's a little bit of a busy slide, but this is primarily their survey data. The percents are in parentheses, and it's basically just like the percent of people that agree. So in general, they're very satisfied, 90% with video visits or both. Again, audio only in general just are worse, but that's not surprising. And there's some, unfortunately, generally people are using the telehealth interface because they have a health concern. So most people didn't say their health is better from using it, but that's kind of a weird question to ask anyway. And most of the other results are pretty positive in terms of how veterans felt using these video visits. And so advocacy on a larger scale, these are things that now we can kind of move towards, like, what are the roles for telemedicine? What are the roles for kind of hospital policies and things as we kind of try to preserve patients' well-being? And so the challenge becomes, again, identifying what are these issues in the pandemic, in the digital era of medicine, that require patient advocates to step in and kind of have a voice for patients. I'm just going to take a few minutes to talk about something that I hold very near and dear, and I have very kind of strong opinions on this. So I apologize if that comes through. This is just an article from the peak pandemic about someone dying in the hospital without their loved ones being near, and having to do a final farewell to a loved one over a web. They used like House Party or some web app. Imagine like having to log on to something called House Party to say goodbye to your grandmother, because during the peak of the pandemic, people were not allowed in to see their loved ones. I'm just going to take a minute and just allow for some kind of meaningful silence on that. Like, I think that was one of the biggest humanistic failings of our society that I've ever seen in my lifetime, to be honest. And this is not unique. This played out thousands, if not millions of times, with all the loss of life we had during the pandemic. And there wasn't really much kind of mind paid to what are the realistic pros and cons of infection control versus kind of human rights and mercy. And this is just in an extreme case of someone dying. I think there's other concerns I'll get to in a second about caregivers as well, going through treatments alone, but dying is an extreme case. And I'm a science fiction nerd. I'm actually currently watching all the new Star Trek shows on Paramount Plus. That's not an official plug or anything. I'm not being paid to say that, but I'm a huge Star Trek fan. So I found a Wrath of Khan reference on a editorial I found on this issue, and I just had to kind of quote it because Spock sacrifices himself for the good of the Enterprise, after earlier having a philosophical conversation with Kirk about, do the needs of the many outweigh the needs of the few. This is like paraphrase slightly, but this is a quote from the commentary, or from the editorial, basically saying that it's a very tenuous argument to kind of use the needs of the many to circumvent the human rights of the few. And again, they say if we lose our humanity, it would be our fault. I would argue that these cases are a clear example of having lost our humanity as a society. I know that there are lots of counter arguments to that, and I understand, obviously, as a physician, having gone through the pandemic in the healthcare system, I understand the very real need for infection control, and that, yes, if someone came visit their loved ones and got other people sick, yes, there are like ripple effects that could happen. But again, I went into this with a disclaimer that I have strong opinions on this. So there they are. I personally experienced this a little bit because I mentioned I'm involved with ThyCa and some support groups. I actually was at one and I heard a few patients having very negative experiences with my institution specifically, because again, it's a local support group, visitor policy, which was essentially no visitors. I say visitor policy, it was actually a no visitor policy. And it's taken me many years to get to a good place with my cancer diagnosis and survivorship. At the time I was going through it, I was not in a good place. I was maybe a little bit unique because I was kind of more on the pediatric side of things. I was 20. But like if my parents weren't there, if my partner at the time wasn't there, if my little brother wasn't there, I don't know what I would have done, honestly. I guess I physically would have survived. But I don't know that I would have done well. So I just and honestly, thyroid cancer patients, we have our struggles and our surgery and RAI and lots of things that are scary. But sometimes we see patients that have gone through long courses of chemotherapy and are significantly more run down than I was when I went through treatment with other cancers here, and they were being denied caregivers and visitors. So again, my disclaimer, strong opinions. I thought that was an unjust policy, so I wrote lots of caregiver medically necessary letters with shall we say tenuous justifications. I voiced anytime there was any kind of organizational meeting, I voiced strong opposition on that grounds. I use kind of like an ammunition that hospitals are also very concerned with patient satisfaction scores. And so I was saying this was a negative driver of patient satisfaction scores because, hey, you got to speak the language of the people that are making the decisions, right? In the end, I will say it was kind of the inertia of safety won out and our visitor policy didn't really change until things got better. But, I think history will judge us, but on some of this, I think there's lots of kind of history will judge us moments with the pandemic of how we handled it in general, in all kinds of ways. But this specific thing really, really stuck out to me as a patient advocate, and I really think it was egregious. But again, there's, I'm sure, just as many strong opinions the other way that if you brought those 10 family members in, it would have been a super spreader event. So, again, I like to go to the data. Are there data that actually this was harmful? There was one study that showed that 18% of patients in their study altered their treatment plans during the pandemic. And that's something that actually seems maybe a little bit low. I mean, we saw patients postponing routine screenings, routine cancer care. And, we kind of thought it was due to their own risk of exposure. And you do see that that's on the list. But kind of maybe unexpectedly at the time, but now, in light of all these issues I'm now talking to you about, a lot of the people actually postponed, at least partially due to the strict rules about visitors and the strict rules at hospitals. And so, I mentioned that there's going to be a lag time of data, how video visits affected us. I think, unfortunately, we're going to see in the next 5 years a huge boom of like preventable cancers that have presented late. To some extent, we're already seeing that, but I think the data is going to bear that out more and more. Then, unfortunately, some of these issues led people to change their screening, who maybe didn't get a colonoscopy, maybe postpone their treatment, so kind of presented at a later stage, that kind of stuff. And so this was surprising to me that in some ways it intuitively made sense to me, but again, I'm also aware of my own bias and strong opinion on this, but like seeing that it actually did contribute to a significant proportion of patients changing their cancer care plans, I think gives some validity to the importance of this. And when you look at how patients with companions versus patients without companions do in terms of their emotional well-being, again, I think intuitively this makes a lot of sense, but I mean, total emotional score is worse, anxiety is worse, depression is worse. So is this surprising? No. Did it seem to matter at the time to people making these decisions? I would argue no. So, I think there was a lot of harm that was done. I think we need to learn from this and kind of in the future weigh public health policies carefully against humanistic concerns and human rights, especially when it comes to end of life issues, which can never kind of you only have one chance to say goodbye to a loved one, right? So, I think we need to listen empathetically and adaptively to the needs of patients as they arise, rather than default to this is the policy, it is what it is. And I think we need to carefully collect and analyze data with scientific rigor to guide policy without biases, and including my own biases, which again I acknowledge on this issue. But yeah, I think that this was something that we can all learn from, and I think if nothing else, it kind of illustrates some of the tension of modern patient advocacy issues that I'm hoping to kind of spur discussion on as part of this. And so I'll kind of come back to this question. So what other issues might be out there that require advocacy in this kind of digital era of medicine? I alluded to this before, but I think more and more we're going to see healthcare moving towards a consumer model. And I think there's, kind of good and bad to that. I think that I live in Silicon Valley right now, so disruption culture is a thing that I hear all the time, but it's essentially like you can, if for those that aren't familiar, it's essentially like you have a taxi cab industry for, almost 100 years. And then Uber, who's like a tech startup, says, we're going to come in and disrupt the cab industry. And we're going to redesign it from the ground up to make it more user friendly for people to use their phone to get a driver. So, you can imagine, and it's already happening to some extent, there's people that say, okay, we have this big bloated healthcare system, I'm going to come in and disrupt it. Now, the challenge, I think, with healthcare is that because it is such a bloated system, we have, a lot of legislation and things in place like HIPAA that kind of favor healthcare's inertia how it is. So I think there's actually a lot of unique challenges to disruption culture in medicine. But I will say that it kind of highlights a larger push from kind of a grassroots kind of patient expectations that aren't being met. You'll see these commercials for these kind of remote medicine, primary care doctor that kind of use preventative care and metrics, kind of saying all the right things. That's directly kind of addressing a need that's not being met when you go down the street to your local kind of now big hospital conglomerate. And I think that, we ignore that at our own peril. I think hospital leadership might be focused on their new like electronic medical record quality that like adds to like now they can more accurately document their smoking cessation in their office visits. And like, not that that's not important, but I think a lot of times they're so in the trees they don't see the forest. So I think that there's a risk that if we don't stay ahead of this as a healthcare system, that kind of patients might make the decision for us as healthcare providers. That's kind of my opinion, that there's kind of a big kind of underlying frustration that a lot of patients have with like kind of the lack of connectivity to their own care and lack of agency. That we have agency in now every aspect of our lives. And we don't really have it to some extent in healthcare because again, there still are barriers and kind of inertia from historical ways of how it's been. So again, I think we ignore that at our own peril. I've kind of posted some things. There's a lot of these research kind of nonprofits and think tanks and things coming up with kind of what healthcare consumerism looks like and kind of doing research on outcomes and how that relates to, what choices you might make, but not kind of the traditional endpoints that are defined by our, medical research establishment. And, I'm also acknowledging that I speak to you as part of that establishment, but also as someone who can look in from the outside as a patient advocate and say, are we really doing the right thing by our patients? And so, I think that there's also a risk that if we as a healthcare system, and that includes patient advocates, and patients themselves as kind of like coming together with the people that we actually trust with our care, and solve this, we leave ourselves open to the famous case of Theranos, where that promised to give people agency over their health because you can take a finger stick blood test and essentially know the meaning of life. And, they overpromised a lot of stuff, but yeah, you could essentially take control of your healthcare with a finger prick at home. We leave ourselves open to these kind of charlatans that are going to, again, and some legitimate companies, but we leave ourselves open to these things that might not be as good as promised and are being delivered by people that we wouldn't necessarily trust with our care. I think we can have a whole separate hour talk about whether disruption culture for medicine is a good thing or a bad thing. And maybe in the future, I might actually be interested in doing something like that. But I just bring it up because I think that's something where patient advocates have to be very vigilant, because there is patients with cancer are vulnerable, and a lot of things promise, and if they overpromise, then that can be an issue. And so I think these are just another area where kind of patient advocates need to be vigilant. Again, so I kind of used this before, but I'm going to say it again. I don't preach to have all the answers. I think I can, from my experience on both sides of the aisle, so to speak, see the questions. I was kind of laying out a thought process by which I approach patient advocacy and some specific issues that I've become fixated on as we've kind of gotten into this pandemic telemedicine world. I think that these kinds of questions aren't going to go away. If anything, they're going to continue to kind of snowball and blossom, because now we're living in a world where Zoom is an everyday reality, where telemedicine is an everyday reality. And so if anything, again, as we get into this longer term period of these being an option, we're going to have more and more of these types of issues coming up. And I think we have to be vigilant. We have to be communicative, and we have to be thoughtful about how we do that to avoid the mistakes of the past, some of which I've outlined what my opinion of those might be. And so I'd just like to thank you all for your time. I always like to kind of try to end on a little bit of a lighter note. So these are just some pop culture references of cancer that I thought are kind of cool. I don't think Walter White's necessarily the best role model, but I think it's cool. The Simpsons did a kind of chemo hair solidarity thing, and Deadpool did a breast cancer awareness thing. So I just think some of that's pretty cool. But yeah, I'd like to thank the organizers of this event for the opportunity to talk to you guys. I'd like to thank everyone else presenting in this awesome program. I mentioned my collaborators that have helped me kind of put this talk together with some of the data, and all of my doctors and mentors over the years, and my own department here. And yeah, I look forward to answering any questions. Thank you guys for your time.
Thank you. So we do have some questions. We have about 15 minutes. So, well, a couple of them are statements. So one person said that COVID had opened the doors to people who live in remote areas that couldn't travel. And then some of it now has been reversed because of facility policies about coming back in or not. For the financial hardship, some wouldn't be able to get timely care. And then also, those that are not close to thyroid specialty hubs, the phone versus the virtual, when they just need to be seen. So they were acknowledging that, airfare 30-minute for a 30-minute face-to-face meeting doesn't seem practical. And also mentions that, lab work now, I get my lab work back pretty much the same time as the doctor does, sometimes even before. So that would be something that would, just be a phone conversation. So I guess they were just kind of talking about, this time savings, the money savings, and that sort of thing.
Yeah. And let me run with that a little bit too. Yeah. So I think I almost said that on my last slide. So some of you were ahead of the game, I guess. But yeah, I think one of the areas I said that video visits are here to stay, kind of as a generalization. That's actually not necessarily completely true in all cases. There's lots of state lines kind of laws about like, oh, I'm in Stanford, but like, Nevada's 2-3 hours away, maybe a little further, but like near Tahoe, like for example, it's like 4 hours away, and that's like right near Nevada. So like right before, like we could take care of video visit patients from Nevada and we would see them. But like right as these kind of healthcare emergency type provisions start expiring, there needs to be a thoughtful conversation about which of these we're going to make permanent. There's even an old provision that technically a telemedicine encounter, if you've only ever seen your doctor by telemedicine, they're technically not supposed to be able to prescribe you drugs. It's like something called, I believe, the Digital Pharmacy Protection Act. I think it's something like that. And that was obviously waived during COVID because, obviously we were seeing people by video visits all the time and prescribing them medications. But there's lots of, I mentioned this kind of bloated legislative burden that healthcare faces. There's a lot of like very specific issues to this going forward. But so when I say that they're here to stay, I anticipate that a lot of these things are kind of going to come out in the wash, and that the inertia is such that now it's going to be here to stay. But right, there's going to be lots of very specific conversations and issues that have to be sorted out before that happens for sure. And I think one of them is, how do we guarantee access for people that are not near these hubs, to give them the benefit? Because again, the geography shouldn't be a barrier to getting kind of world-class care. And if you can get a video visit, like why does that disadvantage you versus someone that can drive in on a whim maybe you can't get off work or, whatever. There's 100 reasons why not, but, right. So I think how do we do that thoughtfully? How do we make sure that it happens? I think that's still ongoing, but I predict it will. I think we will get there.
And that just kind of jumps into another statement here that, this person said that we need advocacy to open up telehealth across state lines, not only as what was available during COVID with the limited contiguous state telehealth, but access to specialists where we have to travel. This particular person traveled from Colorado to Texas, especially in light of fast-moving, rare, and aggressive disease. For them, it was anaplastic thyroid cancer. So she's wondering, or they, I don't want to gender somebody, to whom do we begin this process about, the across state lines?
Yeah, that's a great question. Those types of things, unfortunately, taking a step back, I think in a lot of cases, kind of most healthcare systems are at some level trying to work on the best interest of their patients. But that being said, there are hard, societal constraints that are put in place. So I think these are examples of advocacy that unfortunately have to start with the legislature. Because, I think that, yes, we can argue for certain things in a state of emergency, which I think was done. And that's why we had the kind of provisions we had. But for long-term changes, when things kind of stop being in a state of emergency, I think that has to be fundamentally changed at a legislative level. There have been these kind of weird, even in the very early pandemic, I remember there were sometimes where doctors were just saying, just don't tell me where you're calling from. It's like, I'll just assume that your summer house in California is here. And we're like, I know that's kind of like a flippant way to kind of get around that problem, but it is kind of weird that if you kind of flew to SFO airport and Zoomed us from the airport and then immediately got back on a plane and flew back, that would be fine. But if you did it from the PHL airport in Philly, I'm just from Pennsylvania, so I'll go there. But yeah, if you did it from the PHL airport before you boarded or after you left, it would be illegal. That just doesn't seem to make sense. I think we're going to allow telehealth. I think it should be kind of defined by the physical location where you're practicing the medicine, not where the patient is receiving the care. I think the fix could kind of be as simple as that. But right now, that's not how things are defined. If you're doing an exam of the patient where they are, I believe it's defined as where they are. But yeah.
So this is going back to your Star Trek reference. This individual said that they're immunocompromised. And are you saying with the Star Trek reference that the needs of the many, i.e. general public with healthy immune systems being able to walk around freely, outweigh my need to not die from a COVID infection? Can we not still find a balance instead of pushing for in-person visits for most things, dropping mask mandates, dropping hospital visitor restrictions to keep this person safer?
Yes. Yeah. And I also want to be careful that I'm not going on record as saying I'm against any safety policies that hospitals put in place as a whole. I think that there need to be thoughtful exceptions. That was the larger point I was trying to make. And yes, there are definitely counterpoints to that, specifically people who are immunocompromised, which again defines a large swath of the cancer population. That being said, there's not a ton of research on secondary spread by visitors that actually does increase the risk meaningfully, as long as mask mandates are held and there are appropriate safeguards in place. I'm not aware of too much literature in that space, but right, I think there's just as compelling an argument the other way. I would argue that when someone is dying or kind of going through care, that there needs to be kind of good faith and common sense ways to kind of give meaningful exceptions while at the same time preserving the safety of everyone. So yeah, I totally agree with almost everything you said there. So yeah, I just want to make sure I didn't misquote myself.
There's not another question typed in yet, but I do have a question for you. Well, I have a couple of questions. So what impact does insurance make on the quality of office visits versus telehealth visits? Because I found with me personally, I feel like I have greater attention from my physician when we're on a telehealth visit, even though it could be the same amount, the same 15 minutes that I would see this person in the office. But does that impact anything?
Currently, I believe that they are billed similarly. I think I will admit the medical billing is one of my weaker areas. So to some extent, I can only give you my understanding of having gone through it kind of operationally, like as a resident. I do know that there are levels of office visits that involve procedures, physical exam, that sort of thing. And you can document a physical exam. Like there's what's called like a no-touch physical exam, which is like, but just by looking at someone, like right now, I can kind of, say 3 or 4 things about your appearance on the Zoom call that like you could put in a physical exam, that you're documenting that you're breathing normally, that kind of thing. And so I think, that exam, I don't think kind of rises to some of the higher level codes of office visits, but I think in general, I think during the pandemic, I believe that they were billed similarly to what a consult would be billed at normally. And so, right, the question is kind of, these are kind of things we have to consider as we like talk sustainability. Is that going to remain the case?
So another question I have for you is, this is just a general advocacy, not necessarily pertaining to just an in-person or a telehealth visit, but how do we tell doctors what we need, whether it's in the line of how do I best receive information? How is it that I can communicate with you the best? So how do we voice that as patients to say, this is what I need from you, and can I get that from you, or do I need to move on?
Yeah, that's tricky in that, I said that you have to be your own advocate, but at some level, you need kind of reciprocity from your counterpart on the other side of that. I think the best way to do that is to kind of describe what your goals are and what your kind of fears are, even, I think, and to some extent, and what your things you're trying to avoid are, because those are both pragmatic and emotional concerns. And I think then a good practitioner is going to kind of tailor what they're going to tell you to that. Like, are you a person that wants to know, doc, what would you do if it's your mom, and then I'll do that? Or do you want to know the nuances of 3 different treatment approaches with like incremental benefits from clinical trials? And that's like, there are different types of patients that are both of those camps. And so if you told me you were one and I gave you 20 options with like, oh, this patient in this clinical trial, this group had 14% recurrence and this one had 13%. And like, some people will obsess over that 1%, but some people won't. So, but one thing I find challenging is, I think, which is what you're getting at, is that like the feeling that patients have of not knowing what questions to ask. And so I think you kind of have to some extent, have some frame of reference to even go in and know these things. And so I think that's where support groups can come in handy. I think kind of they're rare, but sometimes even like coaching kind of like things are like kind of just, for those fortunate enough to have someone in the family they can ask, or a friend, I guess, like in healthcare, just to at least kind of sanity check it. But then again, that creates an advocacy issue for those that don't. So, but yeah, it's definitely a challenging thing. I think, again, the best practitioners will sense that and kind of do that anyway. So, but right, if you're feeling a disconnect, it might be kind of that is what's lacking.
Yeah, I know when I prepare for my my meetings with my doctors, I usually am able to get my blood work ahead of time, and then I go through and I kind of analyze and say, okay, these are the questions that I want. And then I also, thankfully now, people are able to come with me when I go to the doctors, which is coming up at the end of the month. And then I always give a copy of my questions to the person who's with me, and then say, make sure I get through all of these questions and listen for what I may miss and that sort of thing. So I do think that that is one thing that I've learned through a group like ThyCa is, how to prepare for the doctor's appointments, how to know what to ask, those questions and things. So I think that's very useful.
Yeah, and you just once again underscore the kind of the real impact that caregivers being included can lead to, and that just kind of underscores the previous point about that. There's data I didn't show about that specific issue about retention and learning being augmented by visitors and caregivers in the visit. It makes intuitive sense, but there is data from those same studies on that I didn't show, but that is also been shown to be the case.
Yeah, it was pretty incredible, and I can't imagine having to go through what I went through and not being able to take somebody with me. That would have just made me like more anxious than anything. So we have 2 minutes left. It looks like we had a couple other questions pop in here real quick. It's hard to know why your practitioner is suggesting a specific treatment plan, especially when so many doctors will suggest different treatments. It's scary to push back when your own knowledge is what is available and what's available is limited. How do you determine if you're on the same page and if you need to find a new practitioner?
That's a great question. I mentioned the NCCN thyroid guidelines. There's almost no case where there's one answer. A lot of the guidelines are written with the knowledge that there is a wide range of acceptable practice standards that different doctors may employ for a variety of reasons. And so, generally everyone recommends what they think is best for the reasons that they have. And so, right, when you're faced with two conflicting things and you don't have that experience, that level of expertise, that's a really challenging situation. I think a lot of times, an example, I don't know your specific example, but like something might come up is, do I get radioiodine or not? Because a lot of in the modern era, we're in low risk patients kind of withholding patients that might have gotten it historically. And I think that goes back to fundamentals and first principles, which is I mentioned about like which decision maker are you in terms of do you want to know all the answers or not? I think there's also a self-awareness of your own risk tolerance. And so, there's the people that again that will go to the ends of the earth to get that 1 extra % free recurrence and are willing to kind of trade potentially more side effects and more issues and more kind of annoyance, more treatments, that kind of thing to get there. And there's some people that are like, no, good enough is good enough. And I want to get back to living my life and minimize the side effects. And so, I think first principles about the kind of person you are and your goals can be helpful. And then again, by communicating those things, the people taking care of you kind of should be able to navigate you to the thing that accomplishes your goals. But that's not to say it's easy. I actually, like, as I talk to people, like perceive that there's a big need for kind of these kind of pointed communications to get people to even have that. You almost need to know the moving parts to even have the self-awareness that I'm describing. So I'm not meaning to say that that's easy, but that would be my advice.
Yeah. Okay. And there's one last question, and I think we can go over 2 minutes to do this. I have had 2 situations where the after visit notes online say we discussed a treatment plan that we didn't talk about. If I didn't have access to the after visit notes, I would not have known this. Is this common these days with technology? These are in office visits.
Yeah, that's unfortunate. I will say that's probably templated text that made its way in there. My approach would be only document what you do. I think because now we know that patients get everything, there's kind of this thing that if it doesn't come up, they're going to get it in writing. And so some physicians will even say, which I think is good, because then at least you're looking for it. If there might be some detail in the note that comes back. If you have any questions on it, don't feel free to contact me. I think that kind of thing is okay. But yeah, my guess is that, do I think that is an acceptable practice, like by kind of a borderline definition of it? Yes. Do I think that that's a standard that I would hold for myself? No. And I think, again, they're kind of one line, kind of almost throwaway lines you could say in a visit that like cushions that blow. So I'm sorry that happened to you. That's kind of my take on that. But yeah, the gold standard is only document what you do and what you talk about. But sometimes, again, these notes become so huge because of some of the other issues I was talking about kind of bloating electronic medical records and things that, it would be a full-time job almost to read all the notes that you put out. So sometimes these things do happen.
Yeah. Okay. Well, thank you for your time today, and thanks for spending a couple extra minutes with us going over time. Thank you very much, Dr. Blomain, for your time today.
Yeah, thank all of you, and thank you for the questions. This is great. I'm glad that I got to interact even indirectly. And yeah, this was a lot of fun. I've never given a talk on this before, and so thanks for bearing with me.
Thanks. Have a good afternoon.
Okay. Yep, you too.
Bye.